Namaskar, good morning. So we welcome you all to the next session of Bajaj Pulse, which is an initiative by Kamalnayan Bajaj Hospital about health education. Today we are privileged and very happy to welcome one of the senior most consultants of the region, Dr. Shrikant Sahastrbuddhe. Welcome, Dr. Shrikant. Dr. Shrikant Sahastrbuddhe is a very well-known pulmonologist, chest physician, intensivist, and he has profound interest in nutritional aspects of intensive care and pulmonology patients. So he is currently the president-elect of ISPAIN, a very reputed organization, and he has been contributing very significantly to the field of pulmonology, intensive care and diet management. So today we'll be receiving some pearls of wisdom for general awareness about the diseases and the facilities which are being provided in these specialties in Kamalnayan Bajaj Hospital. As you are aware, Kamalnayan Bajaj Hospital is one of the most reputed tertiary care center in the region with a vision so that all patients should get all treatment under one roof and no need to go to any other city. So Dr. Shrikant, I would like to first ask you the first question. What is the spectrum of diseases that you look at? So airway diseases or diseases related to pulmonology. What is the spectrum of diseases and has it changed of late?
At the outset, sir, I would like to thank you for the kind introduction. Coming to your question, the common prevalent airway diseases in India, as we know traditionally, starts with chronic obstructive pulmonary diseases. Which is related to smoking as well as to the other forms of pollution like indoor pollution and outdoor pollution. So indoor pollution, we have so many women being affected because of the biomass or chulha which they have used in the villages. As we know that India is a rural country, so about 70 or 80% of the population is rural population. So any female coming with symptoms of COPD, we usually start thinking in terms of the biomass exposure. We know that the air pollution or the outdoor air pollution is becoming worse and worse, and we know the AQI deterioration which happens in metros like Delhi. So smoking, of course, remains the mainstay and the predominant reason for the COPD in India. Along with that, we have other diseases like asthma, diseases related to allergy or inflammatory or hypersensitivity related to hypersensitivity pneumonitis. Also, we have occupational lung diseases like asbestosis, silicosis, those who work in coal mines. And of course, tuberculosis, which we cannot forget in India. We may have many patients with post-tubercular airway diseases, especially post-TB COPD, which is a very common entity. And for that, we at Bajaj Hospital, and I'm delighted to share with you all that we have cutting-edge technology which can diagnose these diseases very effectively in the form of high-end pulmonary function test or a lung function test which we have. Along with that, we may take help of the advanced endoscopy or a bronchoscopy, which we call it in terms of the pulmonary diseases. We have Olympus, which is a high-end bronchoscope at present point of time.
Yes.
And with all these equipments, we can monitor them as well as we can diagnose them effectively on time, along with the malignancies, which also can have a major impact in a timely diagnosis and management, which we all do. And we probably should focus on prevention, and we may go ahead with the preventive aspects of the airway diseases along with the treatment at the same time.
Okay, very well said. Next, coming to India is now called the diabetes capital of the world with similar increasing proportion of obesity patients, and we often come across what is called as OSA, obstructive sleep apnea, and we also understood that OSA is one of the risk factors for cardiac diseases. So I would request you to enlighten us about OSA, obstructive sleep apnea.
It's a very apt question coming from a seasoned diabetologist and a clinician. So yes, obstructive sleep apnea forms a major chunk of unexpected or something which is underestimated, I would say. For a common man who snores a lot at home when in the night, is not aware of the threatening effects of obstructive sleep apnea. And here I would just like to throw a light on a few terminologies which are interchangeably used.
Okay.
Like obstructive sleep apnea, which is a form of sleep disordered breathing. And as we know that Kamalnayan Bajaj Hospital has a high-end Philips polysomnography machine level 1, which we have it here, probably the only one
in the region, yes.
Which would help us to diagnose sleep disordered breathing spectrum as well, including the narcolepsy or the limb movement disorder, along with hypoventilations or snoring, which are not equivalent to obstructive sleep apnea. So as you correctly said, yes, obesity is a disease, and to mitigate that, of course, the preventive aspect is the most important. But once the patient has these kind of obstructive sleep apneas, which is a cessation of the breath in a simple language, where the breath gets cesated or obstructed or a small amount of time, say about 10 seconds, and give rise to something called as obstructive sleep apnea, which are diagnosed very effectively on polysomnography, which we have. And of course, as we know that we may start with corrective steps, including the behavioral modifications, decreasing the consumption of alcohol, having dietary modifications, as you correctly said, and along with that, of course, there are few devices. Once we diagnose it, they are supposed to go to appropriate consultants and take a proper advice from the appropriate specialty consultants for the same, including the oral devices which we use in the form of mandible devices or tongue retaining devices. And of course, when it advances and depending on how objective is the sleep study report, we may go ahead and prescribe a CPAP therapy, or even a home BiPAP therapy. And here I would like to again highlight the important fact that Kamalnayan Bajaj Hospital is also involved in home care therapies, including those who need a home CPAP or a home BiPAP, along with the nebulization therapies, oxygen, and monitoring of the same.
Right. So, as you just witnessed, Dr. Sahastrbuddhe himself is experienced and qualified to diagnose sleep-related disorders and to prescribe whatever required, like CPAP or devices he suggested. And not only that, this is now extended beyond the boundaries of hospital. So we provide the home-based care also whenever, as and when appropriately required. Next question, like Dr. Shrikant, you have been a seasoned intensivist for the past 24 years or so, more than 24 years. Now, what is the change you are witnessing? Like what what's the paradigm shift that has come in the intensive therapy in the last few years?
Yes, sir. It's a very nice question, because what happens is the concept of intensive care, as we know, is not new. But it is a specialty which has a conceptual basis rather than an infrastructural basis. So the thought starts with how evolved particular concept is rather than how advanced the machine is. The machine will come later and the thought probably will come first. So if I would just like to lay down a few of the salient paradigm shifts which you are talking about, is one is IV fluids. As we know that it is, to sound IV fluids feels a very a minuscule of the problem. But as we know that when the advancement in the thought process has occurred, there is a paradigm shift from using simple IV fluid as any IV fluid to the patient to something called as a balanced salt solution, to aim or with the objective of maintaining the osmolarity of these body fluids close to that of plasma, including the sodium, the potassium, the chlorides. Second is, of course, as we know that I am without a stethoscope now, but we know that traditionally doctor means stethoscope. But this is changed in the recent about 10 to 15 years when I mean, it goes back to 1985 when Dr. Liechtenstein from France devised or put forward the theory of using ultrasonography in intensive care. So at this point of time, after so many decades of our evolution in the thought process of how effectively ultrasonography can be used in critically ill patients. And again, here I am very happy and proud to share that we have a dedicated ultrasonography
machine for ICU.
Intensive care unit for the ease and the comfort of the patient, and the care which we probably deliver is a patient-centered care.
Correct.
Rather than looking at anything else, with the affordability which is so very important in this particular part of our country, and without compromising on the quality or the equipments or the infrastructure. So there is this is a very heartening kind of proposition where we have a blend of a cutting edge technology as well as the affordability.
And the expertise, obviously, that is very important. So as you rightly mentioned, we have got a dedicated ultrasound machine, and what you call it is a POCUS, point of care ultrasound, that has been used. So we have got, and as you mentioned, we have got POCUS as well as we have got focus of patient care and the quality of treatment. We want the patient to get recovered very fast. There are, when patients go on ventilator especially, there are certain myths which are surrounded in the atmosphere. So what are those myths, and how to how would you bust those myths?
Yeah, again a nice question, and these things keep on repeating to even the clinician, and they haunt the patients and the patient's relatives more. And this notion that the patient is serious, say for an example of a COPD patient with a chest ailment or a pneumonia patient, and as we know that in an intensive care, if you take the cross section, there are about 35 to 40% of the patient who have chest ailment somewhere or the other. So mechanical ventilation or ventilator forms an important armamentarium in the treatment of these diseases, especially when they get critically ill. So the first myth probably is when the patient is on ventilator, they will probably never come out. It is never like that. With the advancement again in the thought process and the newer machines which have come have the AI which we know that enabled ventilators, which takes into account how best we can wean those patients and how early we can do that. Number two is ventilator is very costly and it is a very complicated machine. But again, after realizing I am still a student, even if we practice for so many years, but we learn so many things on a daily basis. And we have understood that ventilator does two important things to the patient. It delivers a pressurized air and it delivers oxygen. It is the man behind the machine who is important. How can we use it to the best of for the patient's benefit? And if that logic gets applied, then it becomes easy probably for us to handle those machines. Number three is it is something which affects the patient's outcome and the cost which is comes in. When the patient is on ventilator, that means the cost will 100% go up. Probably as an exclusivity for this particular organization, I would like to emphasize this, that we take into account those factors as well, and we probably, if we treat the patient in a judicious manner or in a fashion where it will combine different modalities, taking help of multiple specialty which we have, which will help us to get out of these patients as early as possible and with effectivity, with less and less damage, because ventilator will create some damage. Something which is good will be equally bad, and especially when we were discussing some time back and you raised the point of the post-COVID illnesses. Yes, post-COVID syndrome will definitely form a major chunk of these patients coming in and going on a ventilator. But with these modern ventilators which we have at Kamalnayan Bajaj Hospital, probably it will be a little easy for us to use it for the most benefit of the patient.
Very rightly pointed out, and I would just like to add this, that we have got an armamentarium of equipment that are required for this related to airway diseases. We have got high flow nasal oxygen, that is one of the important requirements.
Yes.
We have got non-invasive ventilators, invasive ventilators, and transport ventilator. Even while shifting the patient also, that transport ventilator Kamalnayan Bajaj has. And as you rightly pointed out, cost should not be a concern, because Kamalnayan Bajaj Hospital is the most transparent organization. It's a charitable hospital. So we would, ensure that the patients would get treated at a reasonably appropriate cost. It will not be too high. Next, I would like to ask you, Dr. Shrikant, as Kamalnayan Bajaj Hospital is highly focused on various transplant services. We have done one heart transplant, around 4 liver transplants, and more than 1500 kidney transplants. We recently got a license for lung transplant and pancreas transplant. So we are hoping to do one lung and pancreas transplant soon. And during this entire endeavor, Kamalnayan Bajaj Hospital has set up whatever is required for this particular, like for heart transplant or for lung transplant and for some other critical illnesses. We have this ECMO machine. So this is the only hospital which has got a functional ECMO machine in this region. So we would like you to describe and its utility of the ECMO machine. Yeah.
Right, sir. As we are into 2025, and very rightly said that we are focused and committed to give the services in the best possible infrastructure.
Yeah.
And the cutting edge technology.
Yeah.
So ECMO, for all of us to understand, stands for extracorporeal membrane oxygenation. And to put it in a very simple language, it is nothing but artificial lung.
Yes.
Which is like taking the blood outside of the patient's body from one end, putting it into that machine, giving that oxygen or delivering that oxygen to that blood which has less blood because of so many diseases which I just tell you, and the blood going inside the patient's body. Yeah. So by this, what happens is these patients can be on ventilator as well, or they can be off ventilators. And so diseases like ARDS or adult respiratory distress syndrome, patients who have bad pneumonias, or those who are struggling with oxygenation,
Yes.
Are the basic people who are beneficiary of these services.
Yes.
You were talking about lung transplant.
Yeah.
So the major indication of the lung transplant being interstitial lung diseases,
Yes.
where again hypoxia is the major issue.
Mm-hmm.
And here ECMO is used as a bridge therapy.
Yes.
When the patient is waiting for a lung, and you put them on ECMO to support them with oxygenation. And here I would just like to add two things that we can also are in a position to deliver ECPR,
Yes.
or extracorporeal CPR. Again, probably this would be one of its kind in the region of
Yes. Yes.
which Kamalnayan Bajaj Hospital would be delivering. And at the same time, there is something called as ECOR, or extracorporeal carbon dioxide removal.
Okay.
So we are talking about the pulmonary diseases like COPD, and it is a level 1 indication where you have a carbon dioxide going up to the values of 100 or 110. You take away this carbon dioxide and make sure that the internal milieu is maintained.
Okay.
So these are a few of the indications and usage of it.
Coming to next, another important aspect of treatment which is often missed or neglected, which is often found, the nutritional aspect of the pulmonary diseases as well as intensive care patients. So how would you in very shortly, briefly tell us what are those aspects which are often missed and which we need to focus on?
Yes, sir, very nice question. Once again, it is coming from a very intelligent doctor, so I have to be very precise and to the point. So, yes, sir, when I started really looking at this particular aspect, as you say, when we are taught the intensive care way back, to say about 25 years back, we start with a mnemonic called as fast hugs bait,
Yeah.
as we are aware, and there are so many other things. But fast is F and it starts with feeding. So they have given importance to the feeding, and that is a very vital aspect of any critically ill patient who has a pulmonary disease as well. Usually I will probably divide it into three broader parts, like someone who comes to the ICU after a major surgery. Can be a cardiothoracic surgery or a oncosurgery or a gastrosurgery. Second is of course someone who is admitted in the intensive care unit, any ailment, and the nutrition pertaining to that. And the third part would be when they get discharged or shifted out from the ICU and they get discharged from hospital to home. So even the continuation of this care, and as you have correctly pointed out, the home care is we are committed to give the continuity of the care not only in the hospital but also follow them up at home. The same probably logic lies in this. So you start with a major operative surgery, and most of the time they are malnourished to start with. So if they are malnourished to start with for a major surgery like say resection anastomosis of the bowel, we need to prepare them beforehand in terms of the protein requirement, in terms of the calories, in terms of the micronutrients, in terms of sometimes immunonutrition based on the evidences. Talking about the intensive care and pertaining to pulmonary diseases, we know that we need to maintain a respiratory quotient of somewhere about 0.8, not overfeeding them as well, because that is equally bad, not of course underfeeding them, and catching up to the nutrition requirement based on this. And again, there are so many factors to this with a multimodal approach, and here we have a clinical dietitian who comes into picture right from the patient gets admitted to hospital or to the intensive care unit. And as a multimodal or multidisciplinary team approach, we would devise a particular diet for particular disease on a day-to-day basis with modifications if required. As a clinician or as a consultant, I should not have this, a thought of demeaning myself, going to a dietitian, asking for help, and that is probably a evolution even in myself which has happened. Because all these things like microbiology or a radiology or physiotherapy or a clinical dietitian, all these departments are equally important to have a good result for the patient. And then of course continuing these things to the post-discharge patient will have a major impact as far as the morbidity and mortality is concerned.
Very nicely put. Very nice and quick response, and very aptly he has mentioned that it's one of the important areas where it's a teamwork comes into play. Another thing which he has mentioned that's very appropriate, that deficiency of micronutrients, deficiency of protein, and the various comorbidities, like patient is diabetic, then post-operatively many of the times patients are kept NVM for prolonged time and they are not given adequate nutrition. That could be the responsible factor for so many these things.
One half a minute response to this, and you have put it. So that's why it happens that when the patient undergoes a gastric surgery. So it's the primary consultant's apprehension to start the feeding as early as 24 to 48 hours. And here, as a team approach, we need to actually sit together and say, okay, it still can be done as early as within 24 hours, not to have or to prevent any nutrition losses. Exactly. Because recovery from any stressful situation, especially a surgery or even admission in intensive care itself, is a stressful thing. It's a very aptly put question.
So, we thank Dr. Shrikant Sahastrbuddhe for his wonderful knowledge sharing related to all the panorama of airway diseases, diet requirements, and the paradigm shift in intensive care. So anyone who is in need of any consultation related to sleep disorders, pulmonary diseases, or anything, we are always available. Please contact Dr. Shrikant at Kamalnayan Bajaj Hospital. Once again, thank you very much.
Thank you, sir.
Thank you very much.